Good morning, everybody. Welcome to our webinar. This is being recorded, so you know, and this is Kristen Steimanoff with Health Outreach Partners. We will get started in just a second. We currently have 21 attendees on the line. Okay, I'm going to get started right now because we have a lot to get through with you today. Welcome to the very first session of the very first learning collaborative of the Social Determinants of Health Academy. As you may know, the SDOH Academy was founded in 2016. It was founded by our colleagues at the National Center for Medical Legal Partnership, and it's a virtual training series, and it's intended to help participants from health centers and TCAs and health center control networks really develop, implement, and sustain SDOH interventions in their clinics and in their communities. The training series has featured a variety of resources and curricula that are coordinated among several national cooperative agreement organizations. There are currently 14 working with the SDOH Academy, and all of you in this learning collaborative will have access to all of the SDOH Academy resources. So let us know if you want access to any of the webinars that have been posted in the past. We can make sure to get you access. This year, the SDOH Academy is really focusing on these 4 learning collaboratives, and this is the very first one. It's all about addressing SDOH in rural areas. So over the next 5 weeks, actually, of this 4-week session, you're going to hear from 4 different National Cooperative Agreement organizations between now and between December 4th. Let me switch to the next slide. Oh, there. Okay. Today, I am joined by my colleague Christina Wharton at Health Outreach Partners, and we're really going to set the stage. This is the first session, so it's going to take a little longer to get through the housekeeping than in subsequent sessions. We'll facilitate some virtual introductions between all of you. We'll introduce the overall 4-session learning collaborative, and then we'll get into the meat of what we're going to be talking about today. So today we're going to talk about some of the key issues and health risk factors facing rural communities, and we're going to start to address the issue of how do you identify unmet need in your communities, and how do you prioritize those needs, knowing that you don't have the resources to do it all. We're going to walk people through outreach and some strategies for connecting people to care that'll take into account challenges and barriers that might be especially pronounced in a rural setting. To introduce Health Outreach Partners, as I said, we're one of the 4 National Cooperative Agreement organizations that will be working with you on addressing SDOH in rural areas. We've been around since 1970, and we're a national nonprofit that focuses on using outreach and other strategies to increase access to care for vulnerable populations and ultimately improve quality of life. We work really closely with health centers across the country, as well as primary care associations and other community-based health organizations to help develop strong and sustainable community health outreach programs. Our colleagues at the National LGBT Health Education Center and at Migrant Clinicians Network will be collaborating to facilitate the 2nd and 3rd sessions of this series. So session 2 is next Tuesday at the same time, and it's going to focus on understanding trauma to meet the SDOH needs of rural populations. We're going to take a break during Thanksgiving week, and then we'll reconvene for the 3rd session on November 27th. And that session is going to be about challenges and opportunities for collecting social determinants of health related data in rural health centers and really being able to use that data to guide your work. Then our final session is going to be on December 4th. And our colleagues at Capital Link are going to facilitate that session, and they'll be joined by a health center representative to talk about financing infrastructure development in rural areas. So we're very excited about what we've got planned for you over the next 5 weeks with a break in between 4 sessions. And so let's get started. Okay, this is what we're going to be doing today. I talked about the topics a minute ago. I want to say a brief word about process. We know that you're all very busy. We'd love to keep you for as long as we possibly can, but we have made a commitment to cover all of the content during the first hour, and we will stay for up to an additional 30 minutes to respond to questions and facilitate discussions between our participants. We'll definitely be taking notes about the good strategies that people share, and we're going to be sharing information that you've already shared in your survey along the way. So even if you can't stay, you'll have access to recordings, to notes, to strategies. I will also say, at the end of every session, we're all going to wish we had more time together, but please remember that your facilitators are all from organizations that have national cooperative agreements with HRSA, and we are here to support you. And we are very happy to talk you through our resources and through the strategies we're talking about one-on-one. So if you hear something that you want to learn more about, we want you to feel very comfortable to reach out to us individually. I want you to take away some really concrete things. So please be listening for specific issues in rural areas that impact people's health that you can talk about when you go back to your colleagues. And that'll be pretty easy for you because you've already told us about the things that really impact your communities. We want you to take away at least tools or strategies for figuring out how to identify what that unmet need is in your service area. And then think about at least 2 strategies that you would want to apply for outreach in your own organization. And finally, think about at least 2 things that you can do to overcome barriers to care for your populations. We're going to be talking about many more things than this, but I'd like you to walk away with these things by the end of the session. So let's talk about the technology we're using, and then we'll go into the webinars a little bit. As you can see, we're using GoToWebinar. And if you experience any technical issues, there is an 800 number you can call. You can contact them directly if you just can't stay connected. That number you might want to jot down. It's 1-800-263-6317. But we also have Liam Spurgeon from our office with us today, and he's on hand to provide technical support. So if you are having challenges and you can type questions into the chat box, Liam can be working with you offline. We've got you all in listen-only mode right now, but we can facilitate virtual conversations with a couple of different communication tools, which we're going to practice and which I'm going to describe in a minute. And we'll have more opportunity for actual dialogue during that office hours session at the end. So during those last 30 minutes, we'll have time to actually do some talking if you all are interested in talking to each other and hearing from each other. But take a look at this slide. I want to show you some of the communication tools. You have the control panel that you're looking at, and you either connected via computer or via phone call. If you connected via phone call, you're going to be prompted to enter an audio PIN. And if you enter that PIN, that's what will allow us to unmute you if you want to talk later. So be sure to go ahead and enter that audio PIN if you haven't already. You'll also see below that orange arrow on the left-hand side, there's a hand raise option. You may have a question and you may want to raise your hand. You also see there's a question box. That's where you're going to type in any question you have, but also any comment you have. So if we're asking you to give us ideas about things that you do in your programs, anything you want to type it right into the question box, and we'll be able to read those off. As I said, the presentation is going to be recorded, so you can listen to this all over again. And let's do some quick introductions and then get into the meat of it. Sorry, let me advance my slide. Okay, we are going to, we're going to try to practice our virtual tools here a little bit. So because we have quite a few participants. We actually had 57 people sign up. It looks like we currently have 40 on the line, so it would take us the whole time to have everyone introduce themselves by voice. So we're going to do a little bit more of a roll call activity. Here's what I want to have you do. First of all, if you are here and joining us from a health center, please type the name of your health center into that question box and your first name. Type the name of your health center and your first name into that question box. So I'm going to be keeping my eye on the question box. I'll start, oh good, we've got some people coming in already. We have Brittany from Cabarrus Rowan Community Health Center. We have Margaret and Doran from CRCHC. We have Catherine from Community Health of Central Washington. We have Tiffany from Isabella Citizens for Health. We have Donna from Central County's Health Centers in Springfield, Illinois. We have Kevin from Community Health of Central Washington. We have Kristen from Bi-State Primary Care Association, Aminta from CRCHC, Mary from Variety Care in Oklahoma, Jackie from CRCHC, Stephanie from Health West in Pocatello, Idaho, Ashley from Shingletown Medical Center in Shingletown, California, and Estella Sanchez from Oak Orchard Health in Albion, New York. Great. We had one or two PCA folks chime in, but if you are from a primary care association and haven't yet introduced yourself, go ahead and type your organization name into the question box and your name. I have some more health center folks chiming in. We have Lindsay and Carrie from Southwest Montana Community Health Center. We have Sabrina, Laura, Terry, and Rob from Mountain Laurel Medical Center. Shatiqua Jamerson from Tennessee Primary Care Association. Angela Castro from Variety Care, Oklahoma. Terry Kennedy from Kansas Association for the Medically Underserved, the Kansas PCA. Olivia Riuda from Montana Primary Care Association. Heather from the Bi-State Primary Care Association. Nat from the Montana Primary Care Association. Tricia from the Kansas Primary Care Association. And Mackenzie from the Tennessee Primary Care Association. And then we have Sandra from Open Cities Health Center. Sandy, thanks Sandy. Lisa Duran and maybe Sharon Crawford from the Tennessee Primary Care Association. Do we have any other health center or PCA folks, or do we have anybody else from a different type of organization that is with us today? Okay, I'm not seeing anything else right now. So this is a fantastic group. Thank you for the introductions and thank you for practicing using the chat box. That worked really well. We're going to practice one more thing and learn some really important things about each other. I'm launching a poll, and I would like you to respond to the following. What is your favorite type of pie? Of the 5 listed, please check an option. 34% voted, 53. We're at 68% voted. I'll give you just a couple more seconds to tell the group what your favorite type of pie is. We're at 71%. That's a pretty good voting record. All right, I'm going to close the poll. 76%. Let's see, of those of you who have voted, there we go. 31% agree with me, pumpkin pie. 28% pecan, also among my favorites. 21 for key lime, 21 for apple, and nobody chose cherry pie as a choice. Okay, good to know. Well, I feel better knowing this about all of you. Thanks again for participating in the introductions, and thank you very much for filling out the survey. I want to just really quickly show you what we heard from participants. There we go. In the survey, when you were asked to talk about the key SDOH-related challenges facing your patients and community members. It was very interesting. Every single person who responded to this survey, and it was most of you, listed low income as a factor. So we know for all of you, income is a serious challenge for the patients that you're serving. Almost everybody, 96%, listed transportation, and 92% mentioned alcohol or other substance abuse issues, and then nearly 80% mentioned geographic isolation and low educational attainment, and lots of other important factors going down from there. We were, again, really happy to hear from you, learn what your patients are facing and what you're working with, and your experiences really are in line with the literature. So we're going to start moving into the meat of the Learning Collaborative, and I'm going to turn it over to my colleague, Christina Wharton.
Hello, everyone. This is Christina, also from Health Outreach Partners, and I'm going to kick off this part of the content part of our webinar today to talk about the issues, risk factors, and health disparities affecting rural areas. So really just to get a good understanding of what we're talking about before we get into the tools and ways to address some of these issues that are going on in your communities. So starting off with key workforce shortage issues, we know that people in rural areas are much less likely to have access to a primary care provider. There are 20% fewer patient to primary care ratios in rural areas versus urban areas. And there's wide variation between the states and different kinds of legislation permitting nurse practitioners and physician assistants to prescribe medication. So also putting some barriers to care for access to primary care in rural areas. Other huge socioeconomic determinants of health in rural areas that we'll need to address today are income, which came up in your polls and also is evidenced by the literature. So key income disparities, the adjusted per capita income is $9,000 lower in rural areas versus urban areas across the United States on average. 25% of children living in rural areas are below the poverty line, so that is significantly lower than in urban areas across our country. And then really key issues that come up around socioeconomic determinants of health, in particular in rural areas, are transportation. So the distances that people have to travel to get to their primary care and other kinds of medical treatment are much longer. A car might be required, public transportation is limited. So that's a huge issue and a barrier that came up in your polls a lot. Additionally, people are less likely to have insurance or to be underinsured in rural areas versus in urban areas. People are less likely to have internet access. So when we're thinking about different strategies to connect people to care, such as telehealth and various web-based portals and things that have come across with electronic health records, that may be inappropriate for some people in rural areas, as you know from your patients. So there's some key considerations. And additionally, homelessness is another impacting factor that you all talked about in your polls, and also it's less visible than in urban areas, so it can sometimes be perceived as less of an issue in rural communities when that's not the case. So all of these factors have contributed to health inequities for people living in rural communities. So for chronic diseases such as diabetes, the prevalence is much higher. Injury rates such as car accidents, vehicle accidents are much higher. Mental health and substance use disorders are higher in rural areas, and that came across also in your polls and the evidence, especially with the opioid epidemic. And also rates of suicide are higher in rural areas. So this is all from the National Rural Health Association, and we also want to talk about a recent study, which thank you very much for taking the time to read this. I got a lot of great questions from you all via email and really encourage that if anybody wants to talk more about the homework and the reading or go through the podcast or had issues accessing any of it, please send me an email. So this study, which is produced by Harvard and the Robert Wood Johnson Foundation, sampled 1,300 people in rural communities this year. So this is very current, from June to August 2018. And interestingly, so they used an open-ended question technique, so grounded theory, where they let the themes emerge from the responses of the participants. So these are really current, and they're coming straight from the participants in these communities' minds and experiences, and not from answering a question about question and answers that were pre-populated for them. So we know that these are really things that are going on, and they are also reflected in your poll responses. So that was interesting. We can look at the overlap a little bit later. So the biggest problems facing local communities were reported to be drug addiction and abuse, and this included the opioids, so that was at 25%. Also economic concerns, so jobs, poverty, and the economy at 21%. These were the top issues that were identified. And then facing families and individuals, financial problems, as well as health and healthcare concerns were also the top problems facing individuals and their families. Okay, and then so going to most urgent healthcare problems, substance use, cancer, and access to healthcare were considered the largest healthcare issues that were urgent health-related problems specifically. So I really liked this study, and I think we chose it because it was looking really holistically at what life is like in rural communities and not just specific health disparities for health problems in rural communities. It acknowledged that there is a connection between people's experiences and these social determinants and their health and well-being. So I thought that was an attribute of the study, and hope you all agree. And then an emerging issue that that's been coming out of the literature more and more lately, but was also very evident from the results of this study, is that suicide is a pervasive problem in rural areas, and that people are perceiving it to be either staying the same or getting worse. And this is in 2008. This is a recent study, so this is even post Narcan, post naloxone, post some of these different interventions that the federal government has put funding in to try to stave off the opioid epidemic across the country. So I think that's an interesting finding. And then lastly, from the Robert Wood Johnson study, the reoccurring takeaway is just how much people are struggling with the financial considerations of healthcare costs rising and cost of living going up and income staying relatively the same, and what this is doing for people and their families' personal overall financial well-being. So this came up as a huge struggle. More than 71% of people said it was a serious problem for them, how to balance their costs of healthcare and the rising costs in their financial situations. So my main takeaway, looking at some of these key things that came up in your poll results and what came up in the literature in these different studies, was that income and finance and substance use are huge issues in these communities. And what I didn't see as much in the Life in Rural America report that I saw very much in your survey responses was that transportation is a huge issue in your communities, that homelessness is something that's really facing some of the patients in your communities, and the language barriers are a huge access to care issue that some of your health centers and your PCAs are dealing with. So we were going to address all. We're moving into the next session now, which is intended to give you some really, really useful, applicable tools, resources, best practices, so that you can, now that we're talking about what some of these issues are, you can really address them using free and available resources. So we're going to move into the understanding unmet need, which will help you prioritize and strategize your programming and use your limited resources to address some of these issues. So we did ask you, and we do very much appreciate that you took the time to respond to our polls and give us this really rich feedback and data, how you were already doing this. So we asked you how you are identifying unmet need, and the majority of you responded either or both patient intake forms at 58%, or other sources. And that I read into your other responses, people had the option to write in, and it looked like it was mostly surveys, focus groups, heavy on the survey, some needs assessments and some data sharing. And I also saw something we didn't mention, which was taking referrals from other organizations as a way of identifying needs that you may not necessarily see in your own intake forms or see in your own patient population. So it's a great way of getting at different communities. So we appreciated that feedback. We'll try to address everything that came up. So the first tool, some of you said you were using this, some of you said you were interested in learning a little more about it. It's one of my personal favorites. So the UDS Mapper is just a really great way of looking at and exploring your service area. It's particularly good, I think, in terms of addressing the things that you talked about, wanting to learn more about transportation. So it has these cool features where you can look at patient origin, so where the patient's addresses, who are going to your health center, or going to other health centers in your community. And it also allows you to look at the distance if you want to explore a service area and put another service point in, see how far people would be willing to drive or move across space to get to your community. So there's different ways of looking at transportation. You can overlay maps, and I will show an example. Also, there are different overlays for looking at income. So at different percentages of the federal poverty line, you can look at 100 and 200, and it takes American Community Survey data. So it has really rich, different kinds of data that's not just limited to UDS data that you all have access to. And it also looks at insurance status. So that's interesting too. You can look at uninsured rates. You can look at underinsured rates, Medicaid insured, Medicare insured, privately insured, and look at these different populations at the zip code level. And recently, addressing the opioid problems and the substance use issues, HRSA has added the medication-assisted therapy tab at the right-hand side. So I'll show you an example of this too, where you can also explore your service area in terms of looking at a number of providers who are giving the medication-assisted therapy for opioid treatment, as well as number of opioid prescriptions per population. I think that's really interesting. And this is one just example that I had put into the UDS Mapper, thinking about what some of you all were talking about, wanting to learn a little more about. So this is a hypothetical service site in rural Texas in Brazos Valley. So that's where the little blue point is, and the red indicates I wanted to see what patients I would be able to get access to if they were willing to drive 35 miles. And it's adjusted for traffic. It has the GIS information. It's really interesting what it can do. You can see where people with access to roads are getting a little more access to this theoretical health center or outreach site that I'm planning. You can see the major roads and highways, so you can see where people are getting in. And this orange color to the left is people where there's been a 10 to 50% insurance change over the last year, so people who are losing their insurance at those rates. So I'm thinking there's higher people without insurance. In this section over here, I want to give them access to primary care. And this blue section over here is the drug poisoning mortality as a percentage of this population. So I'm thinking if I wanted to provide access to medication-assisted therapy or some sort of service that's addressing this need, that's maybe a population where that could be prioritized and targeted. Okay, so also some of you mentioned you are using the HRSA Data Warehouse. And I think it's very clear that it has the healthcare shortage provider area and the medically underserved area data in there. But I think I want to highlight some of its strengths. I think you all that you all could understand that might help your understanding of your service areas a little bit. So one nice thing about this is it explores grants. It literally has every single grant HRSA has ever issued. So if you're interested in academic partnerships or nurse education training programs, you can see what in your area by maps or by exported data file, what grants have been issued in your area. So that's that could be really interesting, as well as looking at the workforce. So it has all the National Health Service core data if you want to see these other training programs that are going on for primary care providers, for mental health providers, dentists, at every level. So I think grants and workforce data is what the HRSA warehouse is probably best for. So moving into the last couple, different kinds of data that you can collect, and this came up in your survey responses a lot. So quantitative data. So using what you already have, everyone is collecting UDS data for your annual reports and your health center grants, or at least your health centers are, and primary care associations are assisting. And so there's a lot of rich data in there that you are maybe collecting in your intake forms and your practice management systems, or data related to income and housing and insurance that other kinds of practices don't have. So that can be used for identifying social determinants of health in different ways. A lot of you mentioned you're either using or want to know more about the Prepare tool. So that's really interesting. This tool is issued by NAC. It's the protocol for responding to patient assets, risks, and experiences. And it is free and accessible, and I'm happy to share more information about it. They also have really neat templates that are already adapted to multiple EHRs. They have Clinical Works, Epic, GE Centricity, and NextGen, I believe, which those are also free and available to you if you're not already using them, and could be built into your EHR system, which pulls me into the next kinds of data that you all may or may not have access to, but most health centers are up on EHRs at this point in practice management systems. So there's a lot of ways you can yield your electronic health record data to address social determinants of health. So you're collecting these different UDS measures. You have this really rich clinical information. If there's more kind of information that you want to collect into your into your practice management system and relate it to your electronic health record if they are already communicating or the same products. You can use if you have access to a health-centered control network, you can use that to leverage some tailoring and some communication between your different systems and try to get access to more data. Another really cool tool, a lot of these electronic health records, now the products come with population health add-ons, apps, which are really easy point and click. You don't need any experience in relational databases to be able to click through and connect data and flag patients even who meet certain requirements to connect some of these for identifying people who are most at risk within your patient within your patient panels, to then identify them and look at them on an ongoing basis. And I do want to also mention that, excuse me, that is also what a lot of patient-centered medical home models require. So I know in CQA personally, in Standard 2 and in Standard 6, they are going to require that you're looking at data at an ongoing basis, analyzing it, doing performance measurement and quality improvement practices on it, and looking at your population health data ongoingly and proactively. So that can be a really interesting way to tie in things that you already need to do for your patient-centered medical home recognition, or maybe you're coming up on a new recognition cycle. So you can tie these things into looking at your social determinants of health using data that you already have and these tools that are already available. And we're really happy to connect you to them and try to run through as much as we can in this very short amount of time. So excuse me, we're talking so much, I'm so excited about this. So one last bit, and a lot of you did mention qualitative data collection as one way that you are looking at social determinants of health. And that can be really important too, because there's just only so much that a form in an electronic health record can capture and will capture. It's very clinical, it's not going to get at deeper underlying issues, and even though health centers are collecting a lot more social determinant data in their intake processes because they're health centers, there's still maybe some information missing. So you all said you do a lot of patient experience surveys and focus groups, using this data for needs assessments. This can be really great ways to enrich and enhance your understanding of the patients you serve in your communities, in addition to the quantitative data, that you're already using for your EHRs and your UDS reporting. So I wanted to also highlight the CAP survey, which is it's the NCQA PCMH endorsed survey, and it's validated. It's free, and it has a lot of really rich SDOH questions. So that tool we can connect you with if you aren't already using it. It's a little long, I will say, but it's validated, and it's very comprehensive. So there are some ways to look at qualitative data a little differently. Some health centers are doing focus groups as a part of their patient satisfaction experience, understanding for their patient-centered medical home recognitions, and otherwise for needs assessments. And this pops us into partnerships for data. A lot of you mentioned wanting to know more about best practices about how to partner to access more data in this day and age where we have so much information, we barely know what to do with it, and everybody's collecting it. So I think that can be very strategic and smart to look at who has what data. Maybe you could partner with a hospital in your area or with a health department, or form your own accountable care organization if you're not already a part of one, and do some data sharing. You could formulate a formal health information exchange to address some of these information sharing, fill in these gaps, and share different kinds of data with different people to look at your community from a comprehensive lens and to be able to address different issues holistically and collaboratively. And I think some really neat ways I've seen people partner, health centers partner, and organizations to do this beyond the ACO model is to look at community health needs assessments, and maybe partnering a health center, maybe a PCA, maybe hospitals, health systems, private practices, and a health department to do community health needs assessments. They're all required in some way to do one on a cycle for their IRS funding. And so you could think of your cycles and maybe do some data collection together, do some of the more time and money expensive activities like focus groups together with pooled resources, and then look at identify the different needs in your communities and address them together and collaboratively. So that could be one really neat way of partnering for data. Okay. And I think that sums up. I know I went through a lot very quickly, and I'm just very excited about it. So I will be here at the office hours. I'm very happy to bring anybody, any kind of resources that I've talked about, connect with you later. Feel free to email me. I would love to get into more detail about any of that because that was just way too fast. But I'll hand the keyboard back over to Kristen.
Great. Thank you, Christina. I also just want to let you all know, I'm sorry if you've seen a little bit of mouse moving around in the background. Liam told me that if I move my mouse and answer questions, you all see it, and I apologize if it's been driving you crazy, but I appreciate the comments that have been coming in. We'll finish our section of the content talking about outreach and connecting people to care, and then try to have some real discussion. But Christina just gave you a lot of tools and strategies for how to figure out those pockets of unmet need. And once you've got a handle on where people are, it's really important for you to understand the specific issues facing your patients. So you can really use excellent outreach strategies to help get at that and to help build trust and break down barriers. We define outreach very broadly at Health Outreach Partners. We describe it as a process of improving people's quality of life by facilitating access to care, by also bringing linguistically and culturally appropriate care directly to people where they live and work and spend time, and by increasing the broader community's awareness of the presence of underserved populations. So we see a bit of an advocacy piece in that as well. All right. Uh-oh. Christina, great. We also asked you about what your best outreach strategies are and your best strategies for connecting people to care. And 3/4 of you talked about doing health fairs and doing outreach at community events. Almost 70% talked about having meetings or doing presentations with other community health providers, other social service providers. About 60% of the people who filled out the survey talked about doing advertising, and a little under half of you told us that you use community health workers. And then about 1/3 of the respondents talked about doing outreach at shelters, at soup kitchens, food pantries, things like that. And then we heard a nice smattering of additional strategies. One person talked about doing a monthly radio show. One person talked about social media posts. And I suspect that if we had asked about those things, we might have gotten more respondents. So again, you know, when we talk about outreach, we really are trying to talk about reaching people where they are, literally and figuratively. And we're talking about both the people who have not yet walked in your door, who aren't patients of your health center, but also people who may be patients and you want to keep them engaged in care. Maybe they really need follow-up care or screening tests and they haven't been in a long time. So these outreach strategies that we're talking about are intended to help you reach new people and sort of stay connected and engaged to your existing patients. But this is really community specific. We've worked with health outreach programs all over the country. And when we ask people where they go to do outreach, we always hear something different. In Washington, D.C., I worked with a health center that did outreach events at least once a month at local churches. In North Carolina, I learned about targeted outreach and health education happening at beauty shops and at barber shops. And in Montana, we were doing trainings around affordable health insurance outreach and enrollment, and trainees talked about going to community events like rodeos to get the word out about enrollment opportunities and the health center and its available services. So you have, you really want to think, what do I know about my community? Where can I go to reach the people who need my services most? And then what you do once you get there really depends on what specifically people need, but also, of course, how much time you have, how many staff you have, what kind of capacity and expertise you have, the relationships that you've built with the different outreach sites you're going to, whether it be work sites or schools. We've heard of people actually, and this is really relevant to all of you who mentioned that low income is a challenge. We've heard of people working directly with schools to get information packets into the backpacks of kids who are on free or reduced lunch programs. So when you are trying to educate families about services available or enrollment opportunities available. That's a very easy way of connecting to kids who might need it, but you have to have those good relationships with the schools. You might be helping people enroll in insurance. You might be doing health fairs where you can offer screenings. There are all kinds of different things that you might do once you find these locations where the people you want to reach are. And then when you're talking about truly connecting people to care, some of it you can do in an outreach setting. So I'm moving over to the right-hand side of the screen, talking about tailoring your service delivery model to what people need. Lots of health centers do have mobile health units, and they set up shop at specific community locations on a regular schedule so people know where they're going to be and when. We understand that a traditional make an appointment at a health center and have people come in at the appointed day and time, that kind of approach doesn't work for everybody. So how can you reach people where they are or how they need with the resources that you have? So if you have a mobile health unit, that's a possibility. Many health centers are using telehealth to connect patients to specialists in other towns or to other health and social service providers that aren't conveniently located. Lots of health centers are really committed to functioning as a one-stop shop. So once you do get someone in your door, how many services can you provide to them on the same day to keep them from having to come back? And then we heard transportation from almost all of you. When it comes to addressing transportation barriers, there are lots of different ways to address it, and not all of them involve providing a ride. So plenty of health centers do directly provide rides to patients. They may have outreach workers with their own cars or with company cars who will literally pick people up from home or take them to their appointments. Other health centers have shuttle services that go between community locations, and they might do this in collaboration with other community-based organizations. Many provide taxi vouchers or bus passes, so if transportation is available but cost is the primary barrier, that can really help. Mileage reimbursement can really be helpful, again, to address the cost barrier if people have friends or family who are able to drive them, but the cost could be an issue. We have heard from lots of programs that have navigator services that function kind of like mobility management, helping people figure out how to use the public transportation systems in their communities. And finally, partnerships are a really key way that a lot of health centers work with other community-based organizations to address transportation as a barrier to care. There might be lots of different organizations in your community that have some transportation options and they're not using them all the time. So how can you build relationships, figure out who those people are, and come up with collaborative ways of working with them? Before we move into our discussion portion, I just want to give you some information about a couple of tools that can help you with your efforts regarding outreach and connecting people to care. The first is Health Outreach Partners' Outreach Business Value Toolkit. And we've been doing this work since 1970, supporting health centers to develop strong, sustainable community health outreach models. And it's always been very easy to make the mission case for the kind of outreach we talk about, going into communities, connecting with people where they live and work and spend time, getting them access to care regardless of insurance status. But it can be harder to make the business case to administrators who have real business realities to attend to. And so we developed this toolkit that includes some frameworks that really lay out for you what a comprehensive community health outreach program can look like. And then it also has some very specific financial calculator tools that can help you calculate the potential return on investment for involving outreach staff in certain types of activities. So it makes a case for making a broad, comprehensive community health outreach program cost neutral at least, and potentially even generate some revenue. This toolkit is free for health centers and primary care associations and health center control networks. You need to sign up for need to sign up on our client portal, and you have access to lots of one-on-one TA from Health Outreach Partners, so please let us know if you're interested in taking advantage of that. And the last tool that I want to mention to you is a new toolkit that we developed recently. It's our Transportation Quality Improvement Toolkit. And this toolkit really helps health centers to do a number of things. First, to understand the scope of the need for transportation support in their communities, and then understand internally what might be the cost to you of not addressing transportation as a need. So are you tracking the number of missed appointments that you're getting each year, and how many of those missed appointments are due to transportation? And if so, you can figure out how much transportation barriers are costing you every year, and think about whether implementing an intervention that addresses transportation solutions can actually save you money. And then there's a Plan, Do, Study, Act cycle that will help you evaluate what you're currently doing and or test new interventions and sort of improve along the way. So I wanted to introduce those two tools to you. And again, we are available for any one-on-one assistance that you would like with either of those. So before we move into the discussion portion, I want to introduce the next session. And I wonder, I think we can just, let's see, Liam, can you see if anyone from National LGBT Health Education Center or Migrant Clinicians Network wants to say something about the next session? If not, I can just quickly introduce it. I know that they'll be sending an email in the next day or two with homework and resources. Okay. I don't think I hear anyone chiming in. I'll definitely give them a chance if I learn otherwise. But as I mentioned at the beginning of this presentation, the next session, which is a week from today at the same time, is going to be about addressing trauma in rural health centers, rural populations, and really going through the trauma-informed care model. Our colleagues at the National LGBT Health Education Center and at Migrant Clinicians Network are going to be leading that session, and they are going to be emailing you all some resources and some homework assignments in the next day or two as they finalize their list of good stuff to share with you. So we absolutely hope that you'll join us for that. And now we do have time for discussion in the last few minutes of this hour, and then, as I said at the beginning, we can stay longer. Let me launch a quick poll for you. And this is it's another choose one, select one of the following. What are you most interested in discussing with your colleagues today, or what are you most interested in asking us questions about? We can talk about multiple things, but we want to prioritize the ones that get the most energy. So you can choose issues, risk factors, and health disparities. You can choose understanding unmet need. You can choose prioritizing and strategizing, outreach, and connecting people to care. And I know it's hard to just choose one, but choose the one that resonates for you the most, and we will prioritize in order of the votes. We've got 44% voted so far. People are still voting, so we will give it another few seconds. We've got 56%, 58%. All right, let me give it 10 more seconds and then we'll close it. We're at 65%. Okay, 70% have voted. That's fantastic. So I'm going to close the poll and I'll share the results. This is great. So 33% of you said that if you had to choose one, prioritizing and strategizing about unmet need is where you'd like to focus our attention today. The next one is understanding unmet needs, so those two might go together nicely. Connecting people to care issues, risk factors, and health disparities, and outreach. So let's just make a quick note of that. And we'll move into discussion. Okay. Liam, do you have a,
I think we have a chance. Alex is called in.
Oh, good.
And so maybe we could go ahead and unmute Alex, and I can do that for us. So Alex, whenever you're ready, you should be able to speak.
Hi, everybody. This is Alex Krogan. Can you hear me?
Yeah.
Oh, great. Hi, everyone. I'm at the National LGBT Health Education Center. I'm a clinical psychiatrist as well. We're looking forward to the next session along with our partners at the Migrant Clinicians Network. And we're going to be focusing on the role of trauma-informed care in meeting needs related to social determinants of health for rural populations. We're going to focus on the fact that truly addressing issues that impact patient outcomes in rural settings and in general involves as a critical part of it. We're increasingly realizing an appreciation of and implementation of best practices related to trauma-informed care, understanding trauma as a pervasive determinant of health that sometimes results in development of PTSD. In many other cases, can manifest in ways that are more indirect and ultimately, through various mechanisms, lead to worse health outcomes. And there are particular considerations in rural settings as well, focused on the way ongoing stress, discrimination, powerlessness, oppression, and structural violence can perpetuate these adverse health outcomes. We're going to focus on post-traumatic growth and resilience as well, and best practices at health centers related to specific strategies and principles that can be applied and are promoted by HRSA and other leading federal agencies. So we look forward to focusing on this aspect of social determinants in rural settings with you, and we'll send out a specific reading in the next day or so. Thank you for your time.
Thank you, Alex. We're super excited about it. Great. Okay. Let's move into discussion, and we can unmute you. So we would love to have this be as interactive as possible. So understanding unmet need and prioritizing and strategizing, what are some of the strategies that you all are using already? Let's go back to that. I'm going to go back to the survey data. Sorry, I'm flipping through right now. We do have a slide. Okay, so people talked about using patient intake forms, using other sources like surveys, focus groups, interviews, needs assessment reports, et cetera, and UDS data. At least 50% of people used all of those things. And then fewer than 50%, about 41% talked about using UDS Mapper, and 20% each talked about using the HRSA Data Warehouse and HRSA Map tools. And then there were a variety of possibilities. Can you type into the question box? I'm curious to hear what some of these other sources people are using. What are some sources that you use beyond patient intake forms, UDS report data? If you can type some comments into the question box, and if you would like to talk about what you do, raise your hand and we'll unmute you.
Just want to give a quick plug. If any of you out there on the call do plan to speak up, if you'd like to participate, I would encourage you to connect via your phone if you haven't already, where it says you have an audio tab on your control panel. There's a selection for computer audio or phone call. That's where we usually get the best connection. So if you haven't already and you'd like to, I would encourage you to do that if you're capable and in a setting where you can, because that's usually where you'll sound the best and the clearest, and we can use whatever you have to say.
Great. Suzanne has said we use the prepare form, and I think we've heard some other people talk about that. I'd love to talk about that in a moment. And then Kevin asks, has anyone gone through local churches, food banks, or social service agencies to send out SDOH screens via SurveyMonkey to broaden the input? Kevin, if you're available to talk, I might let you ask that question in a little more depth and then see if your colleagues have some good answers for you. Liam, is it possible to unmute Kevin?
Sure.
If he's available to talk?
Hey there, Kevin. If you're there, feel free to speak up.
Can you hear me now?
Hi there. Yes, you sound great.
Thank you. So I practice in a rural county in central Washington state, and am part of a community health network, and we are trying to build a care coordination integrated tool to let social service agencies share information about clients regarding their needs. One of the things that we wanted to do first was a broad survey of folks in our community to understand what they would prioritize as needs. But we're strapped by being few people, in a rural county that has a pretty broad geographic distribution. And I was wondering about using technology. Most of our clients have a smartphone, so I think that SurveyMonkey is an appropriate tool to consider. And I was wondering about going through getting buy-in from places like churches, food banks, social service agencies to use their roles and send out the survey so that people could answer anonymously.
And this is the survey you would work with the churches, food banks, et cetera, but the survey itself would be going to their members and their clients and their parishioners.
Right. I mean, we've tried to do a similar kind of survey using paper, but one of the problems is whenever you go to an event, you're only capturing that subset of folks who've gone to the event, and oftentimes the people that you want to survey are people who can't get to the event.
Yeah, we have some interesting, Christina, in a second I'll suggest that you maybe speak to the recent project we worked on, but I wonder if anybody on the line has done something like this. Have you administered a survey through partners like churches and food banks using technology the way Kevin is suggesting? SurveyMonkey is super easy to set up, and anyone with a smartphone or a laptop can certainly use it pretty easily. We'd love to hear from your colleagues if anybody has tried this and what the experience is. I'll keep an eye on the question screen. We'll also keep an eye on the hand raised screen. Think about that and let us know. But Christina, I don't know if you know what I'm referring to, but I know you did a recent project where you were trying to get input from community members. And do you think any of what you did would be relevant to this?
Yes. No, Kevin, I was resonating with everything you were saying. Trying to reach, we were doing a study, and I've done a lot of studies on populations with people who have access challenges with transportation, getting to healthcare, and we really want to talk to people who have multiple chronic conditions, or don't have a car, or they live too far away, people who really are not going to be able to be anywhere. Whereas if they were given a paper survey, or if we wanted them to do an in-person focus group, those are the people who are not going to be able to get there for all the reasons that we want to talk to them. So I think that being able to reach them where they are I think if you think they have access to a smartphone or internet, that an online survey would be really good. And I do like SurveyMonkey because it adapts to a smartphone really well. If somebody doesn't have a computer, but they do have a smartphone, it translates well. And also phone calls, if you're able to call people and if you have that level of intensity for your needs assessment, that can be another strategy for getting people who don't have internet and hearing their perspective.
Great. And, you know, we also did find, we were trying to do focus groups with community members, and transportation was a huge barrier for them, and it was really hard for them to get to places where we wanted to do these focus groups. That's different, obviously, than a survey, but we had to really provide transportation support, whether it was rides or mileage reimbursement. Yeah, getting to community members is a challenge, and you've got to use every trick you can in the book. I'm not seeing any comments specific to that from your colleagues, Kevin, but if people think of any, definitely let us know. Does that help you at all with your question, though?
Well, it's just a thought I had as you were presenting, and I was interested in whether other folks had already done something like that.
Got it. We're not seeing any of that, but someone did just say to Kevin, could they use their Medicaid attribution lists to conduct the survey? I'm not sure if email addresses are required as part of Medicaid registrations. So that's a possibility for, you know, how you gather more contact information from people you have access to, if you can use your own list, if the Medicaid attribution surveys include email addresses.
Could I ask a follow-up question? I'm just
Yeah.
wondering. I'm wondering if it would. I'm thinking it might be a good idea for us to appeal to the state Medicaid payers to see if they would participate by making those lists available. That might be an idea to try.
Interesting, absolutely. And I know in Washington, there's a lot of innovative stuff happening with Medicaid, so they might be really willing to go there with you.
I know from personal experience, it really depends on the state. So that's a consideration.
Great. Well, this is exciting. Keep the comments coming. We'll share this stuff out with people after. But a couple of people talked about using the prepare form. So I wonder if we could just get a couple of comments about that. If you are using the prepare form to understand unmet need and prioritize, would you be willing to speak to that a little bit? Suzanne and Shelley both mentioned that, and I wonder if either of you would be willing to speak to that. Liam, can you see if either of them are still online? And maybe Suzanne or Shelley, if either of you are willing to talk to this, maybe you could raise your hand and Liam could unmute you.
All right, Shelley, let's go ahead and see if we can hear you.
We're not hearing anything yet, but Shelley, you're unmuted.
Are you there?
Yes,
Hello.
you sound great.
Can you hear me? Okay. I couldn't hear anybody for a second.
Yep, you're here.
We use the prepare form when patients come in, and then we enter it electronically in the system. And then the individuals send me a paper copy. And then I follow up with them, like they mark on the prepare form, you know, if there's any issues that they're having, if there's any needs that they have, and then I follow up with them with a phone call to talk personally with them to see how we can help them with their needs.
Great. So you do that very direct follow-up. You're looking at what you're hearing. And what's your role at the Health Center, Shelley?
I'm a community health worker.
Oh, fantastic. So you follow up with phone calls. And have you found people to be pretty responsive to that? Are they happy to hear from you? Are they?
Yes, they are. And then, so we do a 10-day follow-up. Well, I do an initial call. And then I do a 30-day follow-up call to see how they're doing and to see if there's any other needs.
Great. And do you, are you also involved, just out of curiosity, but are you involved in helping connect them to their appointments and sort of address barriers that they might have in getting to care? Is that part of your role too, or is that outside of your role?
No, if there's issues with transportation, we also have health tran that we do in our organization, and and so we can arrange for appointments for them that we would pay for.
That's fantastic. We actually profiled HealthTran in a publication that's on our website. It's the Rides to Wellness community. It's really exciting to hear that you're using it, and that's going well.
Yes, it's going very well. We've had many rides, so we get patients to their dialysis and doctor's appointments, and it's going really well here.
Fantastic.
The other thing is if they haven't their own ride, but they still have issues with getting the gas or what have you, we have gas cards that we give them.
Okay, gas cards too. Got it. So yeah, that's something that we found once we started asking health centers, how do you address transportation barriers? Most have multiple strategies, and it depends on their populations and their specific needs and the resources they have. They don't necessarily have enough for gas cards for everyone, but they might be able to do a small handful. So wonderful, thank you.
Shelley, I have one more question for you,
Christina.
if you don't mind. This is so fascinating. You said you input the prepare data electronically. Did you take one of those templates from NAC? And if so, how is it working for you?
I'm not positive if it was from NAC. I want to say it was, but I wasn't part of entering that into the system. So I'm sorry, I can't really answer that.
Oh, no, it's okay. But it's in there now, and you enter directly into them. It works pretty well.
Yes, I'm in the administrative office, and so I help with a lot of the resources and such for the patients and clients. But whenever they go to the actual clinics, there's individuals registration and such that input that information directly in there.
Okay, great. So then you can see that too when you need to look at the patient's record.
Right.
Cool. Thank you. That's awesome.
You're welcome.
If Suzanne is still on the line, Liam, could you see if she had anything to add to how they use the Prepare tool? That would be great. If not, we'll go to a different topic.
Yeah, I think she had to step out.
Okay.
That might be my boss.
Oh, okay, good. Great. So she would probably just expand on what you're talking about.
All I know is my supervisor's name is Suzanne. So
got it.
And so that could have been her.
Suzanne Smith? Is it Suzanne Smith, Shelley?
Yes, it is.
Yeah, that's her. Okay. Got it. So she would have told us more about your describing. That's great. A sort of related comment here is from Carrie Taylor. Carrie's talking about how at our clinic we use the SDOH electronic screening in Epic in your EMR. We meet with patients for warm handoffs and ask the questions within Epic as we sit with them. Then the questions and answers are in their chart where the provider can see it, and the SDOH data is trackable in Epic. So that's another great way of using a screening tool to understand unmet need. And then sort of, Carrie, do you have anything you want to add to that, or anything that you could give in the way of advice about sort of how you use that wonderful data then to prioritize or sort of segment different types of patients? Is Carrie still on the line, Liam? Might we?
Yeah.
If she's available to chat, we could unmute her.
All right, Carrie, you're unmuted if you'd like to speak.
Hi there.
I'm here. Actually, this is Lindsay. Both Carrie and I are here, but this is Lindsay. So we actually just started this within our clinic. The SDOH screening tool in Epic is kind of a brand new thing, and we've decided as we roll this out, to begin with, we're just going to start doing it with our patients for our warm handoffs. And so far, it's going really well. It puts little colored icons right on the top of their chart when you get into it, based off their risk score. The colored icons can be yellow, green, or red, I believe. That way, anybody that gets into their chart can see immediately kind of where I guess, in, you know, what their life situation is and where they are at risk. And so it is helpful. But like I said, we did just start this, and so far it's going really well. And I do know that on the back end, all the data that we are getting is trackable, and obviously we haven't been doing it long enough to really capture much yet, but we literally just started like a month ago. So
great. Well, that's excellent. And I love that, hearing about those icons that just at a glance tell you, you know,
yes.
You might be dealing with someone at very high risk who you really want to spend a lot of time with. And do you all do things like huddles or anything before patient appointments to sort of know who's going to be showing up that day or earlier in the week? I know lots of health centers are doing a lot of that around team-based care. Do things like that facilitate your process at all?
Yes, so there's 4 care managers here at the clinic, and we're each assigned to a different pod of providers. And every day when we come in, we look through the appointments and we go in and visit with our providers about them, and we try and capture at least a couple a day that we think would be appropriate to step in with.
Great. Wonderful. Thank you so much for sharing that.
Yeah.
And Lindsay, I have a quick question for you too. This is great. I know that this is a recent, you said within the 1 month that you're collecting this SDOH data and Epic, but do you know if there's any future plans, you or Carrie, to incorporate it into quality improvement teams, if you have it, anywhere where you're looking at data on an ongoing basis and trying to do performance assessment activities and quality improvement projects and different population health initiatives?
You know, I'm not really sure. I feel like if my supervisor were here, she could be able to answer that, but I'm not sure. I believe so, but I can't really answer to that right now.
Okay. It's really new. Okay. Thank you. Just kidding. Really great.
Great. I'm going to pivot a little bit. We got a couple of comments from Tricia Harkness, and Tricia, thank you for really flagging cost as an issue. One comment was earlier during the presentation, and Tricia said that although some EHRs have the Prepare tool, there may be significant costs for implementing the form. So I would love to hear if other people are, you know, facing that challenge and how they might be dealing with it. And then another related comment that Tricia made when we started having this conversation is that implementing new solutions are often front heavy with costs. How do health centers fund these efforts? Through grants or partners, or investing their own funds for the potential to gain reimbursement? I think we might learn a little bit more about that in the 4th session when Capital Link talks about financing infrastructure, but we'd also love to hear how are people dealing with this cost, whether it's getting the Prepare tool into their EHR or financing new solutions. Are you getting grants? Are you going in with partners? Are you investing your own funds in hopes of a return? If anybody has any comments about that, please either raise your hand and Liam will unmute you, or type it into the chat box and we'll share that. Is Tricia still on the line, Liam? We can let her speak a little bit more to both of these issues if she would like to.
She is. Tricia, you're unmuted if you care to share some of your impressions.
Yes, I work with the Kansas PCA, and so you know, we're starting to explore some of the things like community health workers and that kind of thing. But you know, generally when we're working with FQHCs, they tend to be somewhat resource strapped. They have a lot of people doing a lot of things. And you know, limited resources, and so I know a lot of our health centers use grants, but I know that some of them are partnering with like folks that help with homeless and some of those other types of things. So I was just curious how some of the others have their health centers addressing that.
Great, thank you. I'm not seeing any comments right now or hand raises, but that is food for thought. We'll keep that question out. And again, I think that the capital financing discussion at the very beginning of December might help to give some possibilities for that. But thank you. And then I think we'll switch to a new topic in a moment here, but I did just want to, there's one more comment that we haven't talked about. And Kevin Walsh, this is from you again. I'm not sure what it's specific to, but you have said that we felt it necessary to change the wording to address our patients with a grade 3 to 4 health literacy level. Was this, Kevin, specific to the Prepare tool or specific to some SDOH screening tool of the Prepare tool? Okay, great, thank you. Wonderful, okay. So let's move to people, really prioritized understanding and prioritizing unmet needs. Do you have, sorry, Christina, do you want to jump in?
Sorry, I'm going to jump in. This is not Christina, this is Liam. I just noticed that Shelly's hand was up. Shelly, I'm not sure if this was just from before or if you wanted to chime in again, so I'll just unmute you once more, but if it was from before, feel free to just have it.
Yeah, I checked with Suzanne, and our Prepare form was not from MAC, it was from NACH. And in regards to the cost, it was, because someone had was wondering if it was expensive to implement the form. For us, it was $1,000 to implement it into our ECW system.
Oh, got it. Clinical works, okay. That's interesting. And do you have a health center control network?
We're getting some funny little musical interludes for everybody.
No, I'm sorry, I don't know that.
Okay, thanks.
All right.
That is helpful to think about. So while the form is free from the National Association of Community Health Centers, there may be some costs associated with getting it built into your system, and that is maybe something that a health center control network could do, or maybe something you could, if you are part of an accountable care organization, you could vouch for in some way if they have some interest in getting that data from you to use for a community health needs assessment, or to understand their own patients better, if they're sharing patients with you, if they're going to their hospital and are getting their primary care from your health center. So that could be one way to look at that. And some primary care associations are more involved in connecting health centers to ACOs, so that could be one way maybe to check it out with your primary care association, see if that's something that they're getting into. So just a couple ideas. But
Great.
Thank you so much.
Yeah, and thanks for letting us know about that cost and where you got it. I think that's really helpful for everybody. How about if we move a little bit into talking about issues and risk factors? That was another topic that was prioritized by people when we asked what you wanted to talk about during this section. And I know, a lot of people talked about income, transportation. A fair number of people talked about connecting with homeless populations in their surveys, substance use. What are some of the things that are standing out to you, and what do you want to hear from your colleagues about, like, gosh, we are really finding ourselves challenged at dealing with the opioid crisis, or we're really finding ourselves challenged by reaching out to our homeless populations. What are other people doing? Go ahead and let us know what you're doing that you want to talk about, or what you're challenged by that you want to hear a little bit more about. If you could type into the chat box, into the question box. Not seeing anything quite yet, but what I will do is go back to the survey results and try to talk a little bit about what people said. So again, low income was a big issue. And Christina, if you remember, some of the things that you presented from the from the report that just came out. If there's some interesting things that you think we should discuss, we could talk about that. But what are some of the issues that are facing your community members? We really did hear a lot of people talk about the challenges of reaching and connecting with their homeless populations. And I wanted to make sure that you all know that one of the 20 national cooperative agreements is the National Healthcare for the Homeless Council, and they have a lot of fantastic resources and curricula and strategies and webinars and learning collaboratives, and they do such a good job of working directly with health centers to help address issues in homeless populations. I want to make sure that you're aware of them. But, okay.
I think that's an important point, Kristen, that the way homelessness can express itself in rural areas is a little different, and it is not, that data is not collected in the American Community Survey, or it's possibly not even collected as easily. You know, if you're asking a person face-to-face or using a prepared tool, they may not. You may have to ask that question a little more in a nuanced way if they're living with somebody for a prolonged period of time and more of a doubling up situation versus not having a place to live. It can be a little bit harder to get at that information. It's certainly not as publicly available through some of the tools that we're talking about. So the American Community Survey data that's in the UDS Mapper has really good income information on levels of income, and even how many. Now we have information number of prescriptions of opioids out there, so because we know that we need to understand where the densities of these opioid prescriptions are. But I think that one of the places where it really is lacking is identifying people who are experiencing homelessness, and especially in rural areas. So it would be interesting to hear if anybody has identified a best practice for finding people who are in that situation to try to address that social determinant.
Mm-hmm. We, a few years ago, we've been around since 1970, and historically we worked with health centers that serve migratory and seasonal agricultural workers. But back in 2009, we officially expanded our scope because we were getting requests from so many health centers to help with outreach support for additional populations, and we developed what is called our National Outreach Guidelines for Underserved Populations. We had 30 years to become experts on doing outreach with farm worker populations, but we didn't have 30 additional years for every new population we might want to work with. And so we worked with a handful of other national organizations to develop these guidelines. And there's some really nice specific strategies about doing outreach. And I remember that some of the strategies that came out in working with homeless populations included, you know, if you identify people who are living on the streets or living under a bridge, go and try to connect with these people where they are, but make sure to understand that if you are connecting with people living in those circumstances, you are going into their homes. And so being very respectful and aware of all of the issues that might be coming up for them, that this is the space they're trying to occupy. But as Christina said, a lot of these surveys really don't get at the full definition of homelessness as defined by HRSA, and it includes doubling up and not being stably housed. So there's a lot more out there than I think often gets counted. People wanted to talk about connecting people to care, so I want to see if anybody is using some of the strategies that I mentioned when I was talking about that. Maybe you could practice your hand raise function. I'm curious if any of you can either raise your hand or type into the chat box. Does anyone use a mobile health unit? Does anyone have a mobile health unit and go around to different locations and provide services on something like that? If you do, raise your hand.
Shelly, is that your hand is raised?
It is. We have a mobile dental unit, and we go around to the schools so many times per year.
Great. Mobile dental unit, and you go to the schools. How many schools do you go to?
I believe we go to 2 or 3. Okay. I know we just started telehealth in a second school, so I know that it's 2 school systems for certain.
Great.
Go ahead, please, go ahead. And I think you mentioned your community health worker, and I remember reading a lot in the survey results that a lot of the participating health centers were doing some cool stuff with community health workers. Can you describe your role a little bit and other community health workers in your organization and how you connect with people?
Sure. My role is I connect individuals with various resources. I also educate them in different areas like diabetes, or we just finished a training on what to do when your child is sick. So, and then I'm also an educator in the Kidney Foundation, Chronic Kidney Foundation. I also do Medicaid applications, and I'm a certified application counselor, so I do applications for the Affordable Care Act. And then I also have helped set up telehealth in one of the schools to get that started. And
you sound really busy. That's great.
Yes.
How's the telehealth worked? Pretty well?
Yes, it has. And right. We have one. We have one in another school that's been there maybe a year or two. I've just been here for a year, so I'm still learning everything. But we just opened another one in another school district. And yes, it's going well. It's very needed. It's helpful to the parents as well as the kids, so the parents don't have to leave work and all that. So
that's great. That's wonderful. Thank you for sharing that. We had another comment from Anthony DiBenedetto. DiBenedetto at Oak Orchard, and Anthony doesn't have a microphone available at this time, but he mentions that they have a mobile dental unit that also visits schools and summer school programs. So yeah, it is neat to hear how frequently folks are using mobile units to expand access to oral health care. We've got just a couple of minutes left. I think we could talk about a couple of more strategies and then wrap up. Is there anyone else who's using telehealth? And I can't see all hand raises, so if either of you see a hand raise, because I didn't see the last one, but is there anybody else who's using telehealth that would be willing to speak to that a little? When we were preparing for this Rural Health Learning Collaborative, we thought that might be something that a lot of people were doing, but it's interesting that it hasn't really been mentioned much in the survey. Okay, I'm not really seeing telehealth folks. That doesn't mean it's not happening, but what other things? How many of you are, how many of you are trying to do that one-stop shop thing where you try to serve people with as many things as possible once you get them in the door? If you do something like that, could you raise your hand and we'd love to unmute you and hear a little bit about what you're doing? We know that that's something that a lot of health centers really prioritize. You get someone in the door, what all can you do for them while they're there? And it could be anything from referring them to behavioral health right on site, or referring them to WIC services right on site, or any other combination of things. Okay, well, I'm not seeing any comments, but that's okay because we are at time. I am really thrilled with how many of you stuck around for this discussion. We have been taking notes, we're saving the chats.
We're absolutely available to you. I feel like we just ran through a lot of resources, and we got to talk about some of them, but not all of them. If you want to be connected to anything and you don't see it in the resources in the shared folder in Dropbox, or you don't have access to that, please send me an email, and I am happy to schedule time to talk about any of these in more depth and more detail.
Absolutely. I'll mention a couple of additional things for you before we wrap. We're getting a couple of great last-minute responses, so I'm going to share them with you. But Kevin Walsh has talked about giving a warm handoff to behavioral health services once they have people on site, and also about having on-site nurse case managers and social workers. And then Tricia Harkness shares that in Kansas, many of the health centers offer medical, dental, and behavioral health services, and some are implementing ophthalmology services as well as connections to community resources. So lots of really creative, patient-centered, responsive ways of getting people as much as they possibly can once you've got them in your health center. Thank you all so much for taking this time today. We're absolutely thrilled to be with you. We look forward to talking with you again in a week, and we'll be talking again about addressing trauma in rural health centers. So we'll talk to you in a week. Take care.
Thank you. Have a great week.